Bismillah ar-Rahman ar-Rahim. Today we'll talk about systemic response to injury. It's a very interesting topic. First, let's start with this small animation just to understand what is going on. Then after that, we'll start our lecture. Specific learning outcomes of this lecture are as follows. First, we want to know what is homeostasis. It's that internal body mechanism to maintain the internal constancy of the body. And homeostasis is maintained by coordinated response of all systems to environmental changes, whether these changes are internal or external, to return to normal physiological status and to promote healing. One of these mechanisms of homeostasis is systemic response to injury. So once we have injury to the body, then the systems inside this body will start to maintain and to return back the constancy of this body which exposed to a trauma. It is well coordinated system, but at the same time it is a lot of systems involved to help the body to get back to its normal constancy. At the same time, it's well coordinated, and also they are not comes on cascade. It comes, or they are not, they don't come in consequences. They comes together, and we have detector, processor, and effector. All of them are regulated by negative feedback. Suppose that we have an injury here. This injury will be detected by the detectors, and then this detector will process the response by a processor, and the processor will have a specific effector. Unfortunately, some of these effectors will again stimulate the detector. Then it will be overload, or it will give a negative feedback to stop the detector or to decrease its potency. At the same time, if it is left it will end up with, which we call it, open loop response. And this is unfortunately will harm the body. So this system, whether the detector system or the negative feedback to this system, should be closed or stopped at a specific point, otherwise will affect the body. At the same time, if we cannot stop it, which is the most likely, most of the time you cannot stop it, but you can help the body to get it in the right way, especially in patients with severe injury. That's why before surgery, we prepare our patient very nicely. So the patient will not have very long starvation. And after surgery also, we have to support the patient to decrease his pain and to decrease anything that can keep this loop open. In cases of trauma, we have to save the patient to make some surgical intervention. Maybe we'll take this patient to critical care. All of this can return the severely injured patient to a situation which homeostasis become possible once again. In severely injured patient, as we have shown in the first animation, the concept of normal homeostasis doesn't apply to severely injured patient. These changes may be helpful in the short term and can be harmful in the long term, especially to the severely injured patient who would otherwise not have survived without medical intervention. In the past, the patients who exposed to severe injury, most of them, they will die in the scene. But in the new intervention, those patients can survive, while if they have been left without any intervention, they would have died. There are variability of this response from patient to patient. But also we have determinant factors that can affect this variability. So the first factor is the type of the injury, whether it is burn or something less than burn, for example. Also, the severity, if it is very severe or just mild or moderate. The duration of injury and the patient. The patient, not the same patient even, can have different response to injury in specific time even. And the variability which is related to patient, we can summarize them into the genetic variability of the patient, age of the patient, and basal health status of the patient. From the previous few slides, I think we know now the purpose of response to injury is to return the patient to normal physiology and to promote healing. So the constellation of neuroimmunoendocrine changes following injury acts to provide essential substrates for survival, like high blood sugar, vasoconstriction, postpone anabolism, because the patient now want to get back to the normal physiology, and also optimize host defense. So these are the effect of the usual and normal homeostasis in mild to moderate injury. The patient post-injury, and all of us, we have been through some diseases like upper respiratory tract infection. After the infection, the patient will have immobility, the patient will try to rest, he will be anorexic or she will be anorexic, and the patient will have catabolic status. After we knew that there are variability of injury, is it dose dependent response? So as much as injury I give, as much as response I will have, this will know it in next slides. Is the response time dependent? And time means that if the patient got hit in the morning will be different than afternoon. So here I think we can give a brief answer about that. For example, it will not be very variable regarding the time except the basal status of the patient. For example, patient who just eat some food, maybe during the injury he will vomit, and then while vomiting, while he is in low conscious status, maybe at this time will get aspiration and etc. And this figure, we will see very important thing, how the homeostasis will start. If we have, for example, severe injury at this point, and it was severe enough to, for example, the patient have cut the spinal cord at a cervical level, maybe the patient will end up with multi-organ failure in the scene, and the patient will be dead on arrival once the patient taken by the ambulance to the ER or to the emergency department. And this is which we call it early death. The second scenario, the patient have mild to moderate injury. They will have rapid recovery by increase of the immunohomeostasis and counter, or as we said, negative feedback or negative to stop this immune response, and the patient will get back to normal. This is also applied for the other system which will take care about the homeostasis during injury. Some of those patients, they will have another injury, for example, infection here. Unfortunately, they will act also with counteraction of the system or the negative feedback for this reaction. And the persistent inflammation will give us progressive immunosuppression as an example. And then it will continue. If we stop the injury here and no further injury and it was mild, everything will get back to normal and the patient will have, as we said, rapid recovery. So taking care about the patient post-injury is very important issue, that to prevent any infection to the patient, to support the patient in all of the stages of the homeostasis. If not well supported, the patient maybe end up with persistent inflammation, immunosuppression, and catabolic syndrome, PICS. And here we will have three scenarios. Either those patients will be discharged to long-term acute care facility and poor quality of life, or maybe they will end up with multi-organ failure again and death. So we have here uncomplicated clinical course, and here we have complicated clinical course. What is the mechanism? The initial detectors in our body is the nervous system and immune system. And those two systems will stimulate the endocrine system, and then the cascade will start. So we have mainly three systems which they will start as detector, one processor, and then the effector will start to appear in the patient. We have two types of detector, either at the site of injury, and this which we call it direct or remote effect of the injury. So the first detector at the site of injury, for example, this patient leg has injury here, then at the site of injury, we will have two main detectors. The first detector is the nerve, which are the afferent nerve. And this is will go to the brainstem to tell the brainstem about what is going on. And this is pain. The other detector at the site of injury, once we have burst cells, then we will have something we call it damage associated molecular pattern, DAMP, which we will talk about it later in a little bit details. Why? Because that the burst cell, the organs inside it will be detected by immunity as an foreign body. The same thing will happen once the patient exposed to bacteria, for example, or virus. But in the virus and bacteria, when the immunity detects this problem, we call it pathogenic associated molecular pattern rather than damage associated. So here detectors are immunity and afferent nerves. The remote effect of the injury, either hypovolemia, it will be detected also by nervous system, which is baroreceptor, or hypoxia by chemoreceptor, hypercarbia by chemoreceptor also, acidosis by chemoreceptor, or as we said that if it is pathogenic associated molecular pattern, we will have exotoxin and endotoxin by gram positive and gram negative bacteria respectively. We will start here with the immunity. If the injury happened, then the organelles inside the cell will activate the innate immunity. And we will know what is the mechanism. How do they stimulate the innate immunity? And then the innate immunity will release specific cytokines. And at the same time, it will inhibit some other hormones. Why? Because this is the effect of the processor of the immunity. The end result, the effector, which is the liver and the brain and the whole body. The liver will have a high hepatic acute phase protein synthesis, and this is mainly by interleukin 6. Pyrexia by interleukin 1 and tumor necrosis factor alpha. The tumor necrosis factor alpha with interleukin 1 and other interleukins with the cytokines, they will all affect the metabolism and the patient will be in catabolic status. Why catabolic status? To make substrate for the injured tissue to get healed. Insulin sometimes will be high, but it will not be effective. But by the immunity, the effect of the immunity on the insulin and insulin like growth factor 1 will be inhibition, and it will inhibit also other hormones like the testosterone and also the effect of the active thyroxine, which is T3. Let's talk about the DAMB, and we want to know the mechanism. How does the injured cells can activate the innate immunity?
What is the media-associated molecular pattern, DAMP? As we see here, the normal cell contains organelles and intracellular substances, and the cell dies in two ways, either programmed cell death or if it exposed to injury or necrosis. In the programmed cell death, because the organelles inside the cell and the cell will shrink, so it will be engulfed with its intracellular organelles by the phagocyte and no immunity reaction will happen. In cases of injury or necrosis, the organelles and intracellular substances will be liberated in the blood and the innate immunity receptors will detect such materials. And these receptors, we call it pattern recognition receptors. After recognition of these organelles and substances, the immunity cells will elaborate the cytokines and will activate the immunity all over the body. That's which we call it DAMP.
So, this is the effect of the immunity on the whole body. Is there any effect of the immunity on the central nervous system also? So now we have two detectors, and let us say two detectors and two processors. The processor here is central nervous system. First, the central nervous system received the first detection by stimulation of the afferent nerve of the sensory nerve. The immunity here, once it's stimulated, it will give us the following result. Suppose that we have an injury here, as we said, tumor necrosis factor and interleukin 1, interleukin 6, and other will start to be elaborated from the innate immunity cells. At first, we will have activation for the sensory vagus nerve as autonomic nervous system, not sensory as afferent nerve. But this is sensory from autonomic nervous system. And here this will stimulate the brainstem. At the same time, the cascade of inflammation starts. Going back to the central nervous system, we have sensory as vagus. It will inform the brainstem and other part of the brain that we have immune response. So here we will have first arc reflex, like an arc reflex in the sensory central nervous system. But this arc reflex, it will be sympathetic overstimulation. And this will elaborate epinephrine and norepinephrine. The hypothalamus will stimulate the ACTH, and glucocorticoids will come as negative feedback to decrease the immunity here. At the same time, we will have parasympathetic as motor vagus as efferent nerve will come to the area of the inflammation, and it will elaborate acetylcholine, which will give negative effect on the tumor necrosis factor and other all cytokines and other cytokines which elaborated from the immunity cells. And here we call this collectively as systemic inflammatory response. Once it appears on the patient, we call it systemic inflammatory response syndrome. And driven initially by pro-inflammatory cytokines, as we said before, and followed rapidly by increased plasma level of cytokines antagonist also, and soluble receptors. So now we have negative feedback, 3 negative feedbacks on this initial innate immunity stimulation. And they are the glucocorticoids, which come from the hypothalamus, from vagus nerve as motor, it will give acetylcholine, and at the same time from immune system itself, it will give us anti-receptors, and those antagonists like interleukin-1 receptor antagonist, tumor necrosis factor soluble receptor, which is antagonist to tumor necrosis factor, and transforming growth factor beta. If this prolonged or excessive may evolve into counter-inflammatory response syndrome, which is, we call it CARS, and it is just negative for the pro-inflammatory response. If both increase the anti-inflammatory and counter anti-inflammatory together and became very heavy on the immune system, like septic shock or severe injury which complicated by other injuries, it will end up with organ failure or organ dysfunction. And this is very clear for us in the septic shock. So If the response is mild due to the injury, it was mild or moderate, we will have mild to moderate response, and the counter will be mild to moderate, and the patient will end up with good recovery. If it is very high and end up with systemic inflammatory response syndrome, you will have fever, capillary leakage, and this is further effect on the even on the fluid of the intravascular volume, and will end up with organ dysfunction. If we look here for the CAR, which is counter anti-inflammatory response, this is will have high interleukin 10 level, decreased monocyte HLA-DR expression, ex vivo LPS induced tumor necrosis factor alpha production capacity, decrease lymphocyte cytokine production capacity, and increase lymphocyte apoptosis. At the same time, once we have very severe injury, the stimulation of the cell will be different. And here we will have stimulation of T helper 2 if we have severe injury. And unfortunately, will end up with antibody mediated immunity, which is less than cell mediated immunity. And if the stimulation was started by the T helper 2, will elaborate those cytokines, which unfortunately will be weak and will make the patient more and more vulnerable for infection, and at the end, maybe septic shock. Don't forget the arachidonic acid derivative or cholesterol derivative immunomediators like prostaglandin and leukotrienes and lipoxins. Also, they will be secreted during the injury. At the same time, they have negative feedback, or they have negative to suppress them. And those are like aerosolvines or protectins, deresolvines, and marcins. And those we call them pro-resolving, pro-inflammatory and pro-resolving. And the pro-resolving mediators, they will downregulate production of the pro-inflammatory cytokines, clear leukocytes from the epithelial surfaces, promote removal of inflammatory debris, and stimulate tissue generation. Let's here take a look on differentiation between infection, systemic inflammatory response syndrome, sepsis, severe sepsis, and septic shock. What are differences between them? Infection, that you have identifiable source of microorganism insult. The SIRS, which can happen due to infection or due to just injury, as we said, either pathogenic associated or damage associated. Here you will have two or more of the following criteria to mention that this patient is in systemic response syndrome. And you have to look at the temperature and heart rate, respiratory rate, and the WBCs. If two or more of them has disturbance, as we see here, then you can diagnose your patient with systemic inflammatory response syndrome. Systemic inflammatory response syndrome, if it is due to microorganism, then we call it sepsis as infection and SIRS. If This sepsis associated with organ dysfunction like renal impairment or liver impairment. The diagnosis here, severe sepsis. If this severe sepsis have cardiovascular instability, we call it septic shock. After we finish the immune response, now we'll talk about very interesting part, which is neuroendocrine response and metabolism. And as we said in the beginning of this lecture, all of these responses come together. Once we have an injury, and this injury detected by the peripheral nerves, this will inform the hypothalamus, and the hypothalamus will start to respond in stimulation of pituitary to secrete the ACTH, growth hormones, and prolactin. The ACTH will affect the adrenal gland, and this will increase the glucocorticoids from the adrenal cortex. The sympathetic nervous system will be stimulated and will affect on the adrenal also, but on the adrenal medulla, and will increase the adrenaline. And also the sympathetic nervous system will stimulate the pancreas to secrete the glucagon. The end result of this is catabolic status, which is increase in the adipose tissue lipolysis, hepatic gluconeogenesis. How the gluconeogenesis will happen, or how the glucose will be formed, through the breaking down the proteins of the skeletal muscle. So this is the main response, and this we will see what is the rationale of such response. The injured patient, in relation to the metabolism, generally has two phases. The ebb phase, which is during shock, and the flu phase, which can be divided into two phases as catabolic status after resuscitation and anabolic status after recovery. So after the injury, we will have directly, while the patient in shock, during the first few hours, the patient will have ebb phase, and then will be followed by catabolism, which will continue for days, and then anabolism, which will continue for weeks according to the severity of injury and other variabilities. The role of ebb phase: maintenance of blood volume by increasing catecholamine, vasoconstriction, and also aldosterone and cortisol to increase the resorption of sodium and increase intravascular volume. The physiological response of the patient will have decrease in the basal metabolic rate decrease in temperature, decrease auto-consumption, and as we said, vasoconstriction, at the same time, increase the cardiac output by increasing heart rate, and also the effect on the liver will be acute phase proteins. The hormones responsible about this are catecholamine, cortisol, and aldosterone. In the flu phase, of course, in the flu phase, the duration is variable according to the response of the patient, according to the variability of the injury itself, the patient himself, and other variabilities which we talk about them at the beginning of this lecture. And the catabolic status, the role of this is to maintain energy, to give substrate to the area of the inflammation, the area of injury. So all of the substrates will go there. And we will see later on next slide how it happens. Here we will have increase in the basal metabolic rate, increase the temperature, increase auto consumption, and we will have negative nitrogen balance. Negative nitrogen balance simply means that the amount of protein which the patient taken as supplement will be less than what the patient excrete in the urine. And it means that there are some proteins were degraded somewhere else than the protein which the patient received as a supplement. The responsible hormones are insulin, glucagon, cortisol, catecholamine, but here we have insulin resistant. That's why if you go to the ICU, you will find most of the trauma patients, they have insulin drip, while they were not diabetic pre-trauma. Why is that? To manipulate their blood sugar, because they have insulin resistant and they have high requirements for insulin. In the anabolic phase, the role of this phase is replacement of lost tissue. Now it is time to rebuilding the injured area. And here the patient will have positive nitrogen balance. That means there is no degradation of proteins from the body. And the amount of nitrogen which is secreted, which reflects the protein, it will be less than what the patient is taking as supplement, or equal to it, the protein which that given to the patient as supplement. And here the main hormones are growth hormone, anabolic hormone, and insulin like growth factor. We will know now what will happen during catabolism, during catabolic phase of the flu phase. So all of the tissues prefer glucose to be used as source of energy. But as we know, or as we see, that most of the glucose during the trauma are affected by hormonal imbalance which happened to maintain the homeostasis. During this phase, the glucose which is in the liver will not be enough, as we know that the liver stores glycogen, but it is like 80 grams, and this will not be enough for the energy which is needed at the time of injury. And we need a lot of glucose that will go to the tissue and to the areas of injury. And this status, the body mandate production of new glucose. And this is, we call it gluconeogenesis. The gluconeogenesis, it needs substrates, and it is occur in the liver. And the main substrate is protein. Most of this protein found in the muscle. So the first effect of cytokines, cortisol, and T3 in the muscle will be breaking down the protein in the muscle. Somebody will ask that we have a lot of glycogen in the muscle. Why it is not mobilized now while the patient is immobile? So we can mobilize it now to the bloodstream, and this will increase the glucose, so we'll avoid the effect of degradation and the breaking down of the protein of the muscle. The answer is the muscle lack glucose 6 phosphatase, which is very important enzyme to release the glucose from glucose 6 phosphate into the blood. And the muscle prefer to use it as fuel for the muscle itself during contraction. So simply, the gluconeogenesis will start from the muscle breaking down the muscle protein. And this protein will be amino acid, and the amino acid will go to the liver. By the effect of also of cortisol and cytokines, the liver will give us glucose. And this glucose, small part of it will go to the brain, less than 1/3 will go to the muscle, and most of them will go to the bacteria and site of injury and to WBCs, because it is the main area which need the glucose as substrate for the high energy and for metabolism at this status, at the site of injury. So, as we have all of this glucose in the body, but remember that insulin now is resistant insulin. It cannot take this glucose inside the cell. So here, we need some other energy substrate for the other tissues to stay alive. And here we will use fatty acid by the effect of the cytokines, norepinephrine, cortisol, T3, and growth hormone. And this fatty acid will go to the liver to give us ketones, which mainly will be used by the brain. The glucagon is the main stimulant for this process, and insulin is inhibitor. On the other hand, the norepinephrine and epinephrine will be stimulators. Hypermetabolism following injury is mainly caused by an acceleration of futile metabolic cycle. It's limited in modern practice on account of elements of routine critical care. So, by other hand, it's very difficult to say, okay, I can stop gluconeogenesis by giving a patient glucose. Neuroendocrine response to injury, as we said, it's biphasic. Acute phase, characterized by inactively secreting pituitary and elevated counter-regulatory hormones. And then we will have chronic status if the trauma is very severe. And this will associated with the hypovolemic suppression and low serum levels of respective target organ hormones. And will affect the usual metabolism, the usual daily life hormones in the body. And changes contribute to chronic wasting because the whole body is very busy with something else. So the peripheral tissue here, muscle, adipose tissue, and skin, all of them will give us amino acid, especially glutamine and alanine. And will go to the liver. Liver will make gluconeogenesis, and the glucose will go to the immune system and will go to the wound, as we saw in the previous slide. Let us take here something very interesting like glutamine. The glutamine, uh, the glutamine is the essential amino acid. And the role of glutamine in the body is very crucial. It is the fuel of intestine. What is the relation here? Once we have low glutamine, this is directly will affect the permeability of the intestine. And here we will have small intestinal overgrowth of bacteria because patient doesn't use their GI while they are in critical illness. At the same time, the glutamine, which is the fuel of the intestine and the membrane of the intestine, will be affected. And then the bacteria, which is inside the intestine, will be translocated into the blood and maybe will end result with septicemia. Hepatic acute response and during through phase. The hepatic acute phase response represents reprioritization of body protein metabolism towards the liver and is characterized by positive like increase in C-reactive protein, which will increase in the plasma, and negative reactant like it will decrease formation of proteins like albumin and other proteins. The skeletal muscles, as we know that, it will provide amino acid for metabolic support of the central organs tissue, is mediated at molecular level mainly by activation of ubiquitous proteasome pathway, can result in immobility of the patient, contribute to hydrostatic pneumonia because the patient doesn't take full breathing, and maybe to the death if prolonged and excessive. Let us go to negative protein balance and positive protein balance. How can we say that this patient in a negative protein balance or positive protein balance? By calculation of nitrogen, by calculation of nitrogen in the urine. And then we calculate the loss of 1 gram of nitrogen in the urine is equivalent to breakdown of 6.25 gram of protein, which is equivalent to loss of 36 gram of wet weight lean tissue. And here we can calculate that how much the patient is taking, if how much protein the patient is taking or getting as a supplement, and this amount, the supplemental protein amount, and the amount of excreted nitrogen, then you calculate the amount of protein. If the excreted protein is more than what the patient taking, that means we have negative nitrogen balance, and it tells us that this patient in catabolic status. The weight of the patient at the beginning of the trauma will increase gradually or during sepsis and multi-organ failure. Why? Because of the cortisol, because of the aldosterone and reabsorption of fluid, and at the same time the adrenaline and noradrenaline and other hormones. And here we can say if it is uncomplicated major surgery or if it is starvation, because here the patient will not be in flu catabolic status. What are avoidable factors that compound the response to injury? Continuing hemorrhage will increase the response. So you have to stop the hemorrhage. Preserve the patient temperature by covering the patient very well. Give the patient heaters and other things to decrease the risk of hypothermia. Avoid tissue edema by decreasing the inflammation in the tissue. If there are infection, you have to clean it up. And if there are debris, you have to make debridement, decrease the pain. As we know, the pain is the first detector. Increase the tissue perfusion and stop the starvation. Also, you have to move your patient. So these are factors which we have to avoid them to decrease the hypermetabolic status and immune response at the same time. During surgery, surgery is a type of trauma. So we have to use as much as we can minimal access technique, like if we can make it by laparoscope would be better. And once we are dealing with tissue, we have to be very gentle with the tissue. Block the afferent painful stimuli, even if the patient under general anesthesia. While you are cutting, you are still stimulating the end nerves, and they will go as afferent to the hypothalamus, and the response will come. So you have, at least, if you cannot do epidural analgesia, you can use local anesthesia at the site of the wound. Also minimize the starvation and early mobilization of your patients. All of these will decrease the surgical stress response. That's